The topic that has been assigned today is surgical metastectomy for metastatic renal cell cancer. Now, yes. So, just to sort of introduce myself, I live in New Delhi, and surgical metastectomy for renal cell cancer is almost the same scenario for all solid tumors. And quite often now, surgical oncologists like me are sort of in a corner, lots of times, not being able to keep pace with the evolution of newer evidence-based therapies as far as surgery is concerned, when I compare myself to my medical oncologists and what is happening in the medical oncology sector. And therefore, why I'm saying this today is because today also, I'm continuing to fight the same battle and try and save the domain of surgery in advanced cancers, advanced solid tumors. Sometimes you get encouraged when you see results, what Sugar Baker got with peritonectomies, for instance. But there is not enough evidence to build up a case where I can argue absolutely boldly and blatantly with my medical oncology colleagues and convince them. Now, the same scenario, for instance, just to give you an idea of what we're talking about, metastatic renal cell cancer, ladies and gentlemen, about 30% of patients that come to us already have disease at the same time and in the secondary sites. Another 30 to 40% will develop distant metastasis over the next few years. And of all this metastatic renal cancer load, 2/3 that you see are basically multi-site disease, which means there is metastasis not just at one site. We are not talking about one site or what we call as oligometastatic disease. We're talking about multi-site disease. And the commonest sites that you see today is lung, being about 45 to 60%, followed closely by bone at about 30 to 40%. And then, of course, liver and lymph nodes almost the same at about 20 to 30%, adrenals 8 to 10%, and brain 5 to 10%. And there are unusual sites like pancreas. I'm mentioning pancreas because I have a tale to tell you about pancreatic cancer, metastatic disease. Also thyroid, and all other sites which are not in the thoracic and the abdominal cavity can sometimes have unusual deposits from renal cell cancer. And a statement that all surgical oncologists love to make, that renal cell cancer, ladies and gentlemen, by its nature, by tradition, is generally a chemo and radiotherapy resistant disease. Is it not? Look at all the figures. Isn't that why for the last 80 years we have been trying to use surgery even in metastatic disease, right from 1939, when I think Churchill and Barney sort of reported it the first time in metastatic renal cell cancer? And even today, let me assure you, with all the so-called immunotherapeutic combinations and all the VEGF inhibitors, the so-called targeted therapies, complete responses are rare, aren't they? Or am I wrong? So, in such a scenario, wouldn't surgery continue, in essence, to be present in a situation like this? And of course, as far as the traditional thinking of oncology goes, metastectomy in solid tumors, there are only 2 randomized, double-blind clinical trials that are reported in the literature so far. The Anderson Cancer Center in Texas, Houston. One was for non-small cell lung cancer, and one was for castrate-resistant prostate cancer soon after, where it was proven by randomized studies that metastectomy for local control after the systemic therapy added a benefit in more than one situation. So before I begin my 2 words today, what do the guidelines say, my friends? The commonest followed guidelines by most of my colleagues the world over, the NCCN guidelines, the National Cancer Network guidelines, surgical metastectomy is recommended for oligometastatic clear cell and non-clear cell carcinoma as on today. Look at the ESMO guidelines, the surgical metastasectomy for oligometastatic disease, and in all other situations where, for instance, the general condition is good, the disease-free interval after the primary treatment is some say 1 year, some say 2 years, but 2 years, let me be more conservative, 2 years. And if while you're assessing that case, you feel that it is possible to completely resect that metastasis and not have positive margins at resection. And of course, low pathological grade, low T status, and disease, and at the same time, your disease, which is basically a systemic disease, there is evidence and there's potential for control through systemic therapy. The other consortium that sort of has presented facts and various data collections is the International Consortium Against Metastatic Renal Cell Cancer. 6 factors. They look at 6 factors. They look at the T stage, they look at the completeness of resection, they look at the general functional status, the performance index of the individual, they look at neutrophil count, and they look at ESR. 6-factor prognostication, but let me tell you here, while we are talking about prognostication, these are prognostic indices. Can you hear me, sir? These are prognostic indices, and prognostic indices do not necessarily predict better results at surgery, but are, from the evidence that I shall present to you later, will tell you that the results, when measured in terms of overall survival and disease-free survival, what the results say. And when I talk about prognostication, something that we cannot ignore currently and which has shown merit even in the retrospective studies is the subtyping, the molecular and genomic subtyping of metastatic renal cell cancer. And the content, the messenger RNA and the other things that you look at the molecular level, you tend to divide RCC into 1, 2, 3, and 4 categories, and their biology is different. It is most of these prospective studies that have been looked at in terms of literature, which I shall present to you later. NCCRNA1, RCC1 and 4 are bad biology tumors. Don't do well even with oral VEGF inhibitors like sunitinib. But 2 and 3, if you resect the metastatic disease after you've treated it systemically with targeted therapy, 2 and 3, category 2 and 3, and you have completeness of margins, the overall survival and disease-free survival is much better. On what basis am I saying it? What is my current existing body of evidence in the statements that I'm trying to make today? These statements, unfortunately, ladies and gentlemen, come only from prospective and retrospective data of case arms studies from databases. Most of the major electronic databases searches, and I'm selecting about 44 studies, more than about 10,000 patients looked at. There are no randomized clinical trials here. They are going on. The results are yet to come. Not even one randomized clinical study, double-arm controlled blind study, which would convince scientifically that there is the objective responses and the mortality rates are better after adding metastasectomy. But yes, huge body of evidence, electronic databases, medium overall survival, ladies and gentlemen, between 36.5 to 142 months after a complete surgical metastasectomy. Complete, mark my word, complete. And at the same time, something like 8.4 to 27 paltry months after an incomplete surgical metastasectomy. I know that. My retrospective studies and case reports are telling me across the world There is a decrease in mortality and it's significant confidence level intervals of something like 97%. But all these studies that I shall talk about and what they say after that, let me criticize them before I do that. I'm a critic. I need to look at, these are all small, moderate sized studies where there may be a patient bias, where all the oligometastatic diseases and a lot of patient heterogeneity. So really, the scientific value of this evidence is inferior. Otherwise, you go at it site-wise, lung being the commonest. There a group, Zhou et al., as you see, about 1,447 patients, 16 studies, overall survivals are something like 84%, 59%, 43%, 20% at 1, 3, 5, 10 years. Can you believe it? The kind of overall, this is where surgical metastasectomy has been done for lung, where lung metastases have been excised. And lymph node, and in these series, lymph node involvement, incomplete resection, multifocality, size, and of course, synchronicity, where there are multiple, at the same time, multiple sites of these things in the lung. They were all negative in these studies. Another major study, Mayo Clinic, a good 887 patients. This survival at 5 years, 73.6% if I had a complete resection, and 19%, just 19% for incomplete resection. So mark the difference. Another major series of about 191 patients from Heidelberg in Germany, overall survival 41.5% for complete resection, and only just 22.1% for incomplete resection. So while I say that there is enough evidence retrospectively, and when you look at case studies, reports, convincing results, physicians tend to believe if the general condition is good, there is no multifocality in the lung, there just maybe 1 or 2 metastases, there's no mediastinal lymphadenopathy, and one can, the surgeon convinces you that you can get away with a complete resection, then by all means, like the NCCN guidelines say, go ahead. But like I'm again saying, the level of evidence is low. There are no randomized clinical trials. Second side, the bone mets, for instance, there's not much there. In MD Anderson, 295 patients, overall survival at 1 year, 47%. Overall survival, just 11% at 5 years. Massachusetts General Hospital has an overall survival of about 5 years. At 5 years, just 55%. Not bad. But, as far as bones are concerned, local control for palliation and preservation of function is important. So you may be forced to consider that local control if you can't achieve it by another form like radiation. And you're able to do a proper surgical, whether it is resectant surgery for the bone or it is restorative surgery along with it. And if you can think you can do a complete job without leaving negative margins, sometimes in situations where people are young, they are fit, and all other prognostic factors in their favor, and there is need for local control in the bone, then you have to go ahead for it. And I would say, by all means. Liver metastasis and lymph node, almost the same thing. I've got you results from 14 centers in Netherlands, ladies and gentlemen. 33 patients overall survival is at 1 year, 79%, at 3 years, 43%, not bad. And Stala et al., 88 patients overall survival at 5 years, 62%, as opposed to 29% for no resection. Incomplete resection, I'm again repeating, it's a very, very, very important part of my diatribe this evening. Incomplete resection, which means, in other words, positive margins, significant prognostic factor. So keep that in mind. Brain is not a very happy story. Obviously, it gets the highest priority to preserve CN because you have to preserve CNS function. It can be quite distressing, and irrespective of the impact on overall survival, you may have to go ahead with it. Of course, you're competing for SRS. But if it's a solitary metastasis or a couple of small metastases where your morbidity is going to be low, other prognostic factors are there. There are people at MD Anderson report an overall survival of not more than 12% at 5 years. So there are no large surgical series. And I think this MD Anderson series is also a stereotactic radiosurgery series. It's not a surgical series at all. Yes, but if it's a solitary met, the condition is good, you're able to get away without local, because local recurrence is quite high in the brain. So if you think you're in that unusual situation where everything else is for the patient, even when the overall survival will not get impacted, you might be right in going ahead and offering metastectomy for such patients. I'm mentioning pancreas here because in overall survivals of up to 70% have been achieved in pancreas. And I probably the result is not so much the greatness of the surgeon or the technique, but as it would be the basic biology of the pancreatic metastatic disease being indolent. I'm making this statement, I'm saying maybe because there are no randomized clinical trials to back me up. So, to cut this story short, continue waging this war and defending the territory of advanced cancer for my surgical oncologists. There is a benefit of surgical metastectomy, but it's controversial. There's lack of high level of index regarding survival benefit. Currently published reviews support surgical metastectomy in selected patients, and I talked to you about the prognostic factors that I talked about. Complete surgical mastectomy allows sustained free survival, free of systemic therapy. Theoretically and potentially, yes. Particularly in today's day and age where therapies are expensive and patients can get treatment fatigues. And perhaps integration of surgical metastectomy and current targeted therapies is a valid option. Pending results of ongoing trials, ladies and gentlemen, they are yet to be reported. Would be happy to fill you in at a future date when these results come in. Current studies, of course, suggest an additional therapeutic value of surgical metastectomy when done prior to the targeted therapy, as opposed to when done after the target therapy. In intermediate risk metastatic renal cell cancer, the RESORT trial has already told you that. Risk stratification is the key. We've got to get better at this. Like today, you're using risk stratification to sequence targeted therapies in metastatic renal cell cancer. My medical oncology colleagues, I would request my surgical oncologist colleagues to be more welcoming of more research and more evidence-based practices in future, and perhaps risk stratification when we get better at it and we get predictive factors as to which are the patients who will get objective and evidence-based better responses if we had metastectomy. And of course, that has to happen at a multidisciplinary meeting. Decision-making has to be multidisciplinary, and everything needs to be looked at. Predictive factors need to be enunciated, and all a matter of ongoing trials. So, if I send you back and I say today, with all the prognostic factors in the favor of a patient, oligometastatic disease, otherwise fit patient, and overwhelming physician confidence based on multiple prognostic indices, even without randomized clinical trials supporting me, let me be brave that let metastectomy be given to the right patient. And if you feel satisfies these things, go ahead and do it. Otherwise, wait for randomized clinical trial results to come. Thank you very much for lending a patient here.